well, I thought I had to discuss the Ivus images. So anyway, I'll discuss in brief about how to treat an Ivus in stent failure. This has been projected by today morning that we know that why does a stent fail? Because basically expansion problems, lesion coverage, edge dissection, strut apposition, all these have to be taken care of. But when to evaluate an Ivus, two major issues. One is when there is stent thrombosis, you'll see that there is malapposition, underexpansion, edge dissections, neoatherosclerosis, uncovered struts. In-stent restenosis, intimal hyperplasia, neoatherosclerosis, underexpansion, malapposition, and stent fracture. But common between them is underexpansion and malapposition. Now, whenever a stent is basically put, a broken marriage takes place when an underexpansion or a malapposition occurs in a DS or a coronary artery between these two. Now, the main thing that is to be done is vascular imaging is a must. Now, we have to differentiate between what is underexpansion and malapposition. Underexpansion is usually a technical problem, which usually in hard eccentric lesions and especially regions of stent weakness. But malapposition occurs when how many struts, at least more than 200 microns or one strut thickness. To make matters simpler, this is something what I call as underexpansion. This is what I call as malapposition. But overlap of these two things can occur. That is, in one single stent, you can have both underexpansion and malapposition. These are diagrams of underexpanded stent where you can see the stent has not expanded properly. Now, the incomplete stent apposition can occur in up to 10% of the stents, and these are the cases which are identified in Ivus, and you have to go for high pressure dilatation and then finally complete the result. Malapposed stents, you can see over here that this stent is grossly malapposed, and we had the chroma flow previously where we could identify whether it is malapposed or not. But nowadays, if you just inject a contrast or normal saline while doing the Ivus, you can also know whether it is malapposed or not. Edge dissections have to be recognized, especially if they are really high-grade dissection, but the narrowing is more than 4 or the dissection angle is more than 60. So here in this case, for example, you see it's a very wide edge dissection and the depth is quite significant. But silent edge dissections do not have much of a problem. Neointimal hyperplasia, as you can see over here, that these are cases which we see that of neointimal hyperplasia can take place and there can be stent failure, and mainly that can be on the long run due to malapposition or underexpansion. Stent fracture, which has been seen especially in long stents or multiple stents where you can see fractures can take place, where you cannot see the stent in certain images, that will give us an idea on Ivus about stent fracture. Inadequate expansion versus apposition has to be identified because that is the key to have a good long-term results. So let's come back to the case which Dr. Singatavalu had shown. What confuses me actually when I was given the history was why was an angio done when the TMT was negative? But later on today I got the information just now that she had come with an anginal episode just 10 days back. Now, if you see or revise whatever Dr. Singatavalu has shown, he has clearly shown the Ivus where various problems have been encountered at the end of 1 year. Now, as you see the Ivus, I'll go step by step to analyze these findings. So let me analyze it, and it'll give us a gold mine of information how this Ivus run helps us in knowing how the stent failure has taken place. First, if you zoom the part of these unexpanded stent, you can clearly see that there is a portion which is underexpanded. So this is the first observation that I could do for the CD which was given to me, that part of the stent really shows that it is underexpanded. If you go to the Ivus pictures, you can clearly see that there are areas where the stent is totally malapposed. You see what is the stent diameter and you see the vessel diameter. So this is another interesting finding observation which I could find from the Ivus images that were provided to me. The third thing is some neointimal hyperplasia that I can see over here there's some neointimal hyperplasia can be seen all throughout the stent if you analyze the full Ivus run. Next, late malapposition has been there where you can see there is a big gap between the stent and the arterial wall. Not only that, most interestingly is that this could be a case of positive remodeling also, because you can see that compared to the stent, compared to the luminal artery lumen, with the stent after several times, late remodeling positive remodeling take place. Now, this is like what was done in the target procedure. This was happened in follow-up procedure, and this is what happens when the stented area is more than the luminal area. We call it as positive remodeling, and we have to recognize this identity in the long run. My sixth observation was could be an ISR focal or a late stent thrombosis. This was what was an area of interest where you can see this part, which looks like more of a peristent thrombosis is seen. This was the sixth finding that I could get, that possibly it was a late stent thrombosis. Now, if you try to see this, if you try to correlate with this thing that is angio and the Ivus pictures, it clearly shows an unopposed stent, number one, partial thrombus inside the stent, and partial thrombus outside the stent. So this is clearly visible in this Ivus run. The seventh observation that I could do was there are areas of fibrosis and minimal calcification all around the stent and the lumen. And the last observation that I can see over here, that the stent is over and the thrombus extends beyond the proximal end of the stent. So these were the 8 findings I could get on the Ivus run that was provided to me. So this is that no stent strut visible, but I can see a chunk of thrombus here. The ninth one was there an edge dissection? If you clearly see this part at the end, there is definitely a part of edge dissection which looks not very significant, is a very edge dissection which can be clearly ignored. So we have a wealth of information from the Ivus that has been given, which we can correlate with the angio and find out. Number one, there was an undersized stent, 3 millimeter in a 3.5 millimeter artery. The proximal LED was 4 millimeter. Port was required. I was not sure what he has done in the initial procedure. There's a malapposition or a late malapposition. There's NIH. There is positive remodeling observed. There's persistent thrombus or peristent thrombus, that is a late thrombosis, and possibly a small dissection at the edge. So this is all the observations that I could make from whatever was given to me. Now, why did this patient have a stent failure? We always say possibly the procedure is wrong, it was a bad stent, or it's a drug failure. And we know that recently this patient has been switched off from ticagrelor aspirin to clopidogrel aspirin, and possibly drug failure could have been a cause, and possibly was the patient clopidogrel resistant. Just 10 days after the drugs were changed, the patients came with a stent thrombosis. And it is exactly like this hospital dresses, where you see the antiplatelets and the stent thrombosis, something which do not match with each other, and antiplatelet resistance is something that we should know and is a known entity. If you try to see what is the commonest cause of stent failure, malapposition is the most common finding in patients with late and very late thrombosis, and more prevalent in DS than more common in DS patients. Next, this is an article which was just published in 2021, where we showed that intravascular ultrasound for in-center stenosis, a problem well stated, is half solved, and DS undersizing and underexpansion is a very important problem, and imaging has definitely helped us. This is just published very recently, and is from this June, it was published about management in stent stenosis, where they clearly stated to first define what is your problem, prepare your bed well, and finally treat it. And definitely you have to address the mechanical issues first, and depending on that, do intravascular imaging. And based on what type of problem you have to use either a drug-coated balloon, a DS, or a combination if required. So finally, how do I manage this case? I'll upscale the DAPT first. Number one, I'll immediately not rush. I'll put the patient on GP2B3A inhibitors with heparin. Do the check angio after a week. There's no hurry. Patient is asymptomatic. I didn't have the history that the patient was symptomatic since 1 week. Next, still persistent thrombus after Ivus. I'll post-dilate the stent because there's a grossly malapose stent. Do just a plain balloon, possibly a DB, and then do a physiological evaluation for insignificant and stop there. Or if edge dissection significant, then put a second DS at the edge. And post-treatment regimen, possibly think of a SAPT with a NOAC. So what do we learn from this case? All stent thrombosis are not equal. Intravascular imaging, especially Ivus, because of better penetration, can detect all kinds of thrombus, let it be acute, late, or very late. Ivus can clearly delineate the other factors, especially mechanical factors leading to stent failure. Most importantly, late acquired malapposition can lead to stent thrombosis, and treatment has to be tailor-made. So what is the role of Ivus? It is like the third umpire, which waves finally tells you whether this player is out or not, and that is where we say Ivus is the third umpire in stent failure. Thank you very much for the patient hearing.